slide, okay.
Yes, we can see it
Great.
great. And just for awareness, I am going to record this session. We are
Great.
not seeing it yet in slideshow mode. So I don't know if you want.
Okay, yep, you got it. I'm gonna do it right now. Perfect, thanks. Okay, so as Kate mentioned, I'm Sujit Iyer. I do a lot of educational roles here regionally in the Central Texas area. And up until this past year, actually for the last 4 years, I was the director of pediatric ER outreach. My story in that job may sound familiar to many of you in that I was told by some executives and directors that we should do more for kids out in the community. So we are going to make this job title, but we don't really know what you're supposed to do. And we don't really even probably understand what the value in it is. And to me, it was a real story. It was a real lesson in how do you tell the story of the value in improving pediatrics. So I think for most talks, we only remember 2 or 3 things. And if I had to say the most important part of this session that we have together is how do you tell the story of the value of your job is really the goal here. And I'm going to give some examples. I have no disclosures. These are really my main 2 goals, is to give you examples of storytelling to leverage your pediatric champion work and to learn about different modalities to communicate and collaborate with stakeholders. The third is that I will be sharing many resources of which you are already familiar with, but to remind you that by definition, all of us in this work group are here for each other. And one of my golden rules with community ED champions is that your job is never to make new content. So I would urge any of you to reach out to me or Kate or Justin if there's something that you're trying to put together. Before doing that, reach out and see if somebody's already done it for you. So as a background on what Texas looks like here in the Central Texas area, I work in a level 1 pediatric trauma center. So it's really not very relatable to a lot of parts of the country, right? We see 80,000 kids a year. A sick kid comes in, I push a button and there's an avalanche of people to come in. However, this children's hospital is unique in that they are part of an adult hospital network by Ascension, which is the largest nonprofit community healthcare network. We have 10 community hospitals, and the actual market share for pediatric visits in the Central Texas area is a little bit over 150,000 and growing. If you just add up all the kids that are seen in those other community hospitals, you have another 70,000 visits. The reason why I am saying this way is that I said that phrase about 1 million times to every C-suite person who said, we don't do children here, to remind them that as a whole, they saw as many kids as a large children's hospital. And that's just kind of one way to take numbers and to teach people that, in fact, pediatrics is an important part. At small community hospitals in our area, they would see as few as 300 kids a year. And in some of our larger community hospitals, up to 9,000 to 10,000. So a really wide variation when you talk about the communities that we were working with. I would say that most of the balance in our conversations when we try to help the communities was this. Nobody's going to argue with you about making things a safer and better place for kids. And improving pediatric care includes improving and increasing community trust. On the business side of it, it can help with market share creep. If you have another children's facility that's marketing it as such, 10 to 20% of your volume may be going away. And of course, all of the tangible benefits that you just learned about in the last hour are really something that we have to explain. But that is often outweighed by, we're doing fine, right? I don't get a lot of complaints about kids. I have to work on my STEMI and my heart score and my stroke score and all these other initiatives. There's not really any evidence in front of me as an ED director or a C-suite that I have to improve. I'm not getting any Google reviews or any cases to review. And we have limited resources. So why should we dedicate our time? Good enough is good enough. And that you have to know that that's part of the conversation that you're going to be entering. And the way I talk about communication, which each of my pediatric champions in the community is, you are really communicating with 3 levels of people. The first is your frontline staff, the people who do the hard work every day. The second are the directors and managers who have to balance this yin and yang of knowing what their staff is going through and trying to prioritize initiatives. And the last is the C-suite. So I'm going to break it down in that way. So for the staff, just like with the other two levels, I think that storytelling goes a long way. Telling stories about recent pediatric cases that you've had, or cases that went poorly, or cases that went well, and talking about how improving pediatric readiness will actually allow you as a staff member to feel less anxiety the next time you have to go to work if a kid comes. If you had to ask staff about most of their feeling about kids, it is that sense of dread or doom about not being ready or not being prepared if a sick kid comes. It's never for a lack of not wanting to do what's right for a kid. Education sometimes then feels like it's targeted at weaknesses or fears, but the way I look at it is education should be targeted by what your staff says they need to learn about. I think it's important to know that with most frontline staff, there are certain things that just don't work anymore. I don't know how many emails that everyone on this call has ignored today, but I will tell you that that number grows more and more every single day. However, you have this great leverage to be able to communicate at the bedside by being a champion at your own site. I'm going to give you an example of how a one-on-one conversation with a bedside nurse led us to change some of the education that we created, and it really kind of helped to move the needle on an initiative we have. I think making things to be fun in a way that does not feel like burdensome labor in reading or another required module. And we've talked about this during this course about things like scavenger hunts, which really, without you having to say a word, highlight, do you know where the supplies are? Do we have all the supplies that we need? Do you know how to use them? Are great ways to actually engage the staff. I think the other big thing that we saw working with pediatric champions is if we don't talk about pediatrics regularly, then pediatrics doesn't exist. And that's a really important part of communication. Is you can't overdo it with communication, because that's going to really just really kind of get them tired of you. And you can't wait for the next pediatric case to talk about it. So whether that means monthly, whether that means case-based learning, where every single time your group is reviewing cases, there's always a pediatric case to review. You have to figure out what works, but you have to make pediatrics part of the agenda. And for many of these community sites, we went to a monthly communication strategy. I actually put this picture up here to make a point, in that a lot of times you're going to put a lot of work into communication and it's not going to work. And that's okay. So we started by making these great newsletters. They're only one page to read. We put so much content in there, and we could not get anybody to adopt some things that we were trying to push, like let gel and intranasals. It just wasn't working. And we didn't really quite understand why. We had emails, we gave them webinars, none of it was working. This is another example of something that just was not used. And however, there were other things that did work. And so one initiative that we had was to improve child life education. We went out to sites, we delivered in-person education. But the thing that actually solidified child life education was the poster on the left was actually hung up in every single patient room, and actually hung up in the bathrooms. And that kind of great visual space actually reminded parents to ask the staff about comfort holds. And then the second thing that we created was we created these child-friendly carts, so that if you were a nurse or a staff and you wanted to find something for a kid, you always knew that you could go to this cart. And then within that cart, there were prompts about how to use child-friendly language. You can't see this within the drawers, but there were dolls to teach about IVs. There was the most important part of the child-friendly cart, of course, was the iPad. And so you had to get into there to get to the iPad. So actually just that physical structure served as a method of communication. So I think the most important thing whenever we're talking to staff is to understand that when they are listening, what they're trying to really figure out is, why is this thing that you're making me do or trying to do going to actually improve my job? And for some, the angle is it's going to improve the quality for kids. But for many, it's are you helping me improve the thing that it's going to make my life easier? We tried to teach about the use of intranasal medications for almost 6 to 8 months and all the methods that I said. And then we actually went out to a site to a nurse who's always working there, who had been there for about 10 years. And she said, I'm never going to use intranasal medications because I have never seen it work. I've never been a part of a case where it worked. I've never been a part of a case where it made a big difference in how the kid responded to a procedure. So if I haven't seen it or experienced myself, how will I ever really use it? And so from that, we thought about that and we said, well, we can't bring everyone to the children's hospital. So we actually made a short YouTube video that was about 5 minutes long. It went through step by step of exactly what to do, and then actually showed a kid who was a typical toddler with a large laceration, and showed that person then being very comfortable. And so this actually, can you see the video? Okay.
What's your quest this year?
Yeah. Okay.
Well, no, it didn't pop
skip to
up.
that
You might have to
real
do a new
quick.
share. Because it's just showing the slide. Did it
All right,
pop
hold on,
out?
I'm gonna-
or-
Hold on. I'm going to share it real quick if you guys don't mind, because we have a small group. We'll
After the delivery,
stop sharing it
medications
and then I'll share it
with
again.
both distracting items and some juice.
Can y'all see that okay?
Yeah, now we can.
Young
thanks.
children
And we can hear it. So
Okay, great. Well, I'll just show a couple seconds because I think this was the thing that was our communication strategy that actually worked, and it's up online, and I probably, whatever, there's like 1,200 views. I guarantee you that 1,200 people is more than ever read a single email I've ever wrote in my entire life to any of these folks. So
prior to delivering medications, make sure to have the head of the bed at 45 degrees and pulse oximeter in place. You'll often need a partner for delivery medications in young children. Place the atomizer loosely into the nostril, aim for the center of the nose, and quickly deliver medication. There is a noxious taste, especially to intranasal midazolam. As such, you can quickly have the parent comfort the child and deliver sorpaltar juice to remove the noxious taste. As you can see here, the patient is quickly comfortable after the delivery medications with both distracting items and some juice. Young children will generally be less anxious and more comfortable with the environment after delivery medications, during the procedure quite well, considering the stage of development.
and I won't make you guys see the whole thing, but both this one and then later on, we actually see a lot of kids just kind of sitting there happy, smiling almost when they're getting their videos. And that was it. Like that was the magic sauce, so to speak, of then the engagement from the frontline staff that, okay, this is something that we can do, and kind of really prompted then more questions about how do we implement this in our ER. How do you do this if you're in a small community ED and you're trying to explain things? You make them go try to find supplies. You do simulations. You tell them the story of a colleague that had a bad asthmatic or a bad case. You really have to be able to tell this story about why it's important to improve. And that's really the challenge to all of you. I think that when you're in the community, you often feel like you're on an island. And I think that if you're a frontline staff member, you also think that there's somebody else who's going to be reaching out to kind of get this education. And I think hopefully you've learned through this program, there's a lot of external resources. We've talked about EMS state program managers who can connect you all with experts in your state. But one of the greatest resources sometimes is your local children's referral centers. These centers invest money and time and energy in making sure that community EDs have a good, strong relationship with them so that they call them when it's time for a neonate to get picked up or a pediatric patient to get picked up. And simply calling them to say, we would like more education on the following service lines with a cold email or call often goes a long way. I think the second challenge that we all have, and some of you on this call may be in ED leadership, is how do you convince ED leadership that this is important? And I think the angle with pediatrics is often what you see there at the top, which is, although we may not see a lot of kids, not being pediatric ready is high risk. getting from where we are current state to an ideal state is low in effort, and the resources are always available. I think when you're a manager, you're balancing the resources of time as well as education. And so you have to be able to explain what is the risk of having an ER that is not ready. Kate's already talked a lot about the scores tied to mortality. Of course, the new ACS requirements for trauma facilities is a huge leverage point in increasing pediatric readiness. And sometimes what you do is you have to tell the manager that, look, our staff don't know where our supplies are. And this is where things like results of surveys and scavenger hunts can go a long way. Another common barrier is going to be, how do we have the time to train? We always promised that any education that we had would be put offline, but that to review that education would never take more than 15 minutes. And often it probably took about 5 minutes in pre-shift. Most training, as we all know, has to occur during shifts. And as a local champion, you're able to do that by making things online. And it has to align with department goals. So think about what the goals are of your institution. I'm sure that every institution has some risk and safety goals. Just again, if I could just emphasize making resources, I think that I would reach back out to this core group about what people have already created. I get random emails about every 2 weeks about somebody wants something. I just send it to them. There's nothing about this work that the people who are on this type of collaborative that is proprietary. I think we all want to share the things that we've made. And that's the whole point of this type of program. If you are a nurse manager or physician manager, often you can leverage these types of projects to align with goals of promotion for frontline staff. And this is through things like nurse portfolio projects or even physician promotion. One of the other things that ER managers and directors love to do is to compete. And so I mentioned that we have 10 community hospitals in our network. Now, you may not have this breadth of data, and I think we have to acknowledge the limitations in data. But what we did was within those 10 hospitals, we paired every single one of those hospitals to another hospital in the network that was almost at the exact same size and pediatric volume and exact same resources. And then we would share the results amongst them. So if hospital A was doing well with time to albuterol and asthma score, we would share it with hospital B. And almost every single time that would make hospital B then improve in those metrics. And so finding out a way to compare results to a peer hospital can not only help you share resources, but actually cause a little bit of good, healthy competition. And that's the story of the slide that you just saw. We started this asthma improvement project by first telling some local stories about really sick asthmatics that scared a lot of the frontline staff. Really, I wouldn't say traumatized them, but really kind of left a mark in terms of what happened to the kid and whether or not they did the right things. We then we went back and looped back with those hospitals that were kind of pediatrics was fresh in their brain. And we validated the things they did well. And we reviewed with them that there are only 4 things that you have to do for every pediatric asthma patient in our network. That's it. There's nothing else that it's ever asked of you. We need you to understand how to do an asthma score, give steroids, start the albuterol the right way. And in our system, call the transport team for any kid that's scoring high. And just that simple education of, okay, this kid comes in, we need to do these 5 things. That really kind of helped them start the momentum. We then followed up on asthmatic cases for the next 3 months. There weren't a lot, but we gave a lot of positive feedback. And as I mentioned, we shared the time to steroids and time to albuterol for sites and with other sites. And then we sent a lot of praise, both to the ED leadership and to the frontline nurses about that work. So that all started from a single case. And throughout the entire project, we kept telling the same story about that same kid in his asthma presentation. I think maybe one of the most intimidating groups of people to talk to for some is the C-suite. I was no different when I probably first started in this position. And now my favorite thing in the world to do is just to cold email the CNO or the CMO, because you have to understand that if pediatrics is barely on the radar for your ER, it's probably not on the radar at all at that level. And so often you are explaining the value and the meaning behind pediatric readiness at this level. You have to be prepared for the statement that pediatrics is not a focus of this hospital. Hospital administrators have to balance where they put their time and energy. How do you convince them otherwise? You give them the numbers like I shared you at the beginning to remind them that 10 to 15% of people who walk through this door are indeed kids. The screenshot at the bottom right is a summary screenshot that I would give CMOs that actually showed the size of pediatric transfers that they were transferring out every single month. And it really reminded them of, okay, why are they being transferred out? How can we improve this? And then relating your pediatric readiness score to mortality and risk means a lot at this level. I think it's important that we all recognize ourselves as being advocates for our staff. And so being able to tell the story about cases and how it affected your staff and what they're worried about for kids is important. And then I think it's really, really important that they understand that this is usually low in resources, but it must have administrative support. Even if it's simply an email from an administrator that's saying, our hospital is going to score in the top 10 percentile for pediatric readiness, that is all they often have to do. It is also important that whenever you praise the work of your staff, that you let the C-suite know. Keeping them in the loop in communication is very important. And we've already, I think this program has talked a lot about facility recognition programs. That is a great, great leverage point for C-suite types of folks or administrators to say, okay, if we hit certain benchmarks, we will actually have a designation that is important to advertise. I do think that it's important that we mention that communication is not a one-way street and it's not just pushing information. It really is a method to tell folks that you are there to help and to serve. We always focused on these 4 buckets whenever we went to talk to staff. How are supplies working? How is training working? Which has prompted that conversation to create that video where one of my nurses says, this is not working at all. I don't read your emails. Those newsletters are just more words. It's important that you represent communication as being an advocate and asking staff what is it they need you to advocate for and praising successes. And then data when you have it. Although data is very, very important to tell your story, you may not have all the data you need, but when you do have it, you have to be able to share it. I think that this phrase is probably what I've talked to my champions about the most, which is communication is not more work at the end of your project. It is basically the work. And so although all of you are going to go off and take something from this program that you're going to try to implement, if you're not able to tell the story and communicate this, it will not succeed even with the best efforts. And so here are some ideas about how to make communication work at each of the different levels and why it's important. We talked about how to communicate with different staff. I'm just going to share these slides and skip over, but you have to understand what the drivers may be for the different types of people that you're talking to. I think people understanding the bang for the buck here is really, really important. And so increasing the safety for kids with very minimal labor is important. I want to just state this too, is that as leaders, it is okay to acknowledge the difficulties in maintaining momentum. To me, it is the hardest part about this work is putting forth a lot of energy and then maintaining that momentum for pediatrics. In full disclosure, so on the left was a project we did where we increased the pediatric readiness scores for most all of our sites. And on the most important column was the right-hand column, because out of every single one of those pediatric champions, no people were in that role 2 years later, right? And so I think that you have to be able to explain that when you're communicating at a leadership level about why it's important that we continue to communicate about the importance of pediatrics. The graph on the right actually is the same, where we had running data over time, and as we had different performance based on how much focus we were putting on it. This is just a graph that kind of is taken from the PWDC materials. And I think if you don't know where to start, this is a great place to start. You take the resources from today and from the last hour and see what the answers are to these questions and what you could change today. You also have to recognize that you're going to feel like you keep doing this over and over and over again. And that is part of every project. And what we would always say is, let's define what the problem is. Let's develop some solutions. Let's try to implement it. And then let's talk really about what worked and what didn't work. And we did that with every single project. So when we did it with trying to improve infants weighing on a scale, we at first had issues with the equipment itself. And then our solutions to fixing the button solved some of our problems. But then we had some scales that actually just weren't working. So we called the C-suite from the Children's Hospital to donate scales. And we kind of kept, but the only reason we knew these were problems was by communicating all the way from the C-suite on down to fix infant scale issues. We had the same thing with the equipment supplies issue and the same thing with splinting. And in all of those projects, communicating with the C-level people, with executive administrators, as well as experts was really the key. So I think this was my real take home, which is think about how you talk to people at all three of those levels. Think about what is the story that you're going to tell about a real patient, to your frontline staff, to your ED administrators, to your C-suite. Take pride in the fact that your work is important, and how you're going to explain it, and understand that you don't have to create content, that you have a lot of resources, and think about ways to communicate outside of email. That was, I think a small snapshot of some things that worked. I think I wanted to save a ton of time to hear from people about where they're working and what's worked and what hasn't worked. I think that's the kind of the point of the smaller group. So Kate, I'll turn it over to you, but I'd love to hear some other people's thoughts.
I mean, I think that was amazing just to hear you speak to all this work, Sujit. I mean, I love hearing you say it's not about building content, because I think so many folks here are like, oh my gosh, I have to do all of this by myself. And I also think that you are an example of how this work can start small of, oh, well, let's just look at our readiness, and oh, I'll just start doing some outreach to other sites. And now suddenly you are in this position that you are in because you are at a national level, because you've really built out this awareness around pediatric needs. And so I think that you are a case in point of the example of how this work can become bigger and make an impact, but it takes time to do that. But I don't know if folks want to just kind of, to your point, Sujit, you wanted to just kind of hear who all is here. I'm sure people have questions. So do folks are willing, if you don't mind turning on your cameras and saying a hello. Great. We'd love to see you.
Don't be shy.
I have a question. My name is Amanda Peter Smith. I'm a nurse practitioner, pediatric nurse practitioner in Omaha, Nebraska. We have a children's hospital that I used to work at in the ER. That's kind of regionally, nationally known, Children's Hospital and Medical Center of Omaha. I work at the Boys Town Hospital, Boys Town National Research Hospital, which is a small hospital. I mean, we have like 15 pediatric beds and 6 PICU beds. We are full all the time right now because of COVID, but routinely our census and acuity is low, especially compared to the work I did, or the acuity and census lows that I had at Children's in the ER when I worked there. And so I guess a couple questions I have about the project you're working, or you're talking about specifically now, is with the data sets that you have on, how many patients are being seen. And I guess let me just add a little bit more context to where this question is coming from. We right now, because we're a secondary hospital, pediatric hospital, we don't get a bulk of the admissions that go to Children's. What we get is basically leftovers if Children's is closed, or there's been some, just playing in the sandbox type of stuff where other hospital systems in our metro area will patients will ask specifically to be sent to Boys Town instead of children. So we do get some of those from outside hospitals, those kids from outside hospitals, and they are mostly afraid of children. The question I have around your data sets is, so I work at Boys Town. It sounds like your data sets of, hey, this ER is seeing 10,000 patients a year, or this ER is seeing 750 patients, or this is how many pediatric how many pediatric transfers you've had. How do you get that data because you're in that health system? And if so, is there a way to get that data that's public information, or would I need to contact the leadership at, let's say, Bergen Hospital or Lakeside Hospital or Methodist Hospital? These are other hospitals in my metro area that we get kids from. Would I need to contact those hospitals specifically and say, hey, can I get how many patients do you see, to then present them this data of, this is why you need pediatric readiness?
Yeah,
I guess I just am starting
yeah.
from that baseline of like, how did you get your data set? And if it's not public information, how would you suggest I get that data from regional hospitals in my area?
Yeah, and I'll let Kate and Jason maybe chime in on their experience, anyone else. So I think that when you're talking about, I think it's going to be almost impossible for you to get data outside of your own network.
Okay.
Just, it's going to be hard.
Yeah.
And in fact, the effort that it takes to maybe do that is not even step one, right? I think a lot. So we did this a lot because we actually have a competing healthcare network also in our same town, right? And we wanted to do some of this outreach outside of the network. So instead of looking at like total number of patients, I actually just emailed all the medical directors of the competing healthcare networks and said, I would like to give your staff some feedback on patients that are transferred here so that they feel like they understand what happened to that kid once they sent them here. And all that did really was it simply opened the conversation of communication to then say, oh, okay, hey, whenever we have a kid that goes to Boys Town, you just got to email Amanda and she's going to give you feedback. And that really then opened the door to say, oh, hey, by the way, like we're doing this project where I can come out to your site and like go through a checklist with your nurse director, and I can help you figure out if you're ready for kids next time too. So I think in a way, like kind of you offering something to say, I'm really here to just help you with the whatever, like you said it yourself, right? Like a lot of the places are like, just get the kid out of here. Like, I don't want to, like the fear and anxiety. So I think address that issue for what it is and say, I'm here to help you. Please, all you ED directors, here's my cell phone, here's my email. If there's any kid you want to know about that came to us, I'll find out what happened. And then that just kind of starts opening the lines of communication to then for you to introduce the concept of what if I came out there or got you guys on a Zoom and we helped you with pediatric readiness. I don't know, Kate, but that often works is just with the real case.
Yeah, I'm sure others have comments. The only thing I will say, and I completely agree with you, Sujit, is you don't want to start with the data, because starting with the data comes across as punitive and regulatory, which is what everyone of like, well, you're not meeting this level, and that's not the way you want to open the door to readiness. You want to open the door to readiness through relationship building and identifying champions. Yeah.
Okay. And yeah, I would say the other, so the Children's Hospital is our main competitor as far as our population goes. Other hospitals in the region, Methodist, CHI Health, regional hospitals, there's like 5 hospitals in that network. Those hospitals are not competitors because they don't have a pediatric unit to admit to. They're outside EDs that, right, like you said, Children's is in the heart of Omaha, kind of middle of Omaha. But if you live in one of the west lying suburbs, or you're east downtown, or you're, far north, that's not the closest hospital to you. And so you don't go to that, the closest ER. And if that closest ER is Lakeside or Methodist, and they don't have a pediatric unit, and they don't have, pediatric experience, and just like you said, they're not pediatric ready, then they're scrambling to find a place. And like I said, right now we're so busy because Children's is maxed out at capacity with just obviously COVID and then staffing stuff. But and the other thing too that I want to build out these lines of communication and help with too is to write that we're not a second option. Like maybe you think of us first to admit to. because there are enough patients to go around. There are plenty of patients to go
Mhm.
around. And so if I'm building those lines of communication, then maybe we're first in mind, hey, let's call Boys Town and see if they have an opening, a bed, and working with those outlying hospitals where I think it's not even something that's on children's radar because they are influxed with patients
Yeah.
that are overloading the ER and they don't want more. They're like, no, stay home. Only come here if you absolutely need to. So I think building those lines of communication will help them get ready, but then also put us kind of more on their front burner of sending patients to and working with them in more of like a partnership type relationship where it's, hey, you don't have, you're maybe not pediatric ready, but let us help you get ready. And then even when you have patients that, maybe this kid didn't need to be admitted. If you were pediatric ready, you could have treated them in the ER and then sent them home for outpatient follow-up tomorrow, whatever. But if they do need admitted, then you're thinking of us first. So it's almost like a stepwise, let's get you ready. And then even if the kid does really need to be admitted, we're first on your radar. But that's a really great approach of, yes, hey, this is a kid that you sent to us. Let's follow up on this. Oh, and by the way, let's open this door of communication. Here's my cell phone and email and whatever. And if you ever have questions about a kid that's in your ER or you need help, even curbside manager, not curbside, but even managing a kid that's there in the ER and you need an input or you need a second, brain to toss ideas off of or whatever, call us. And whoever's on will be able to help you and then build those relationships out from there. So that's really good advice. Thank you.
Yeah, you're doing great work. I mean, don't be afraid to share that with your leaders, right? Like they would love, I think anybody would love to have a champion like that,
Yeah, thank you.
Cheryl from North Carolina. Seen you in forever. What did you have to say, Cheryl? What are your thoughts?
Well, I don't have tons to say. First, I trying to get on all these calls and everything had gone to my spam box, which I recently found out. So luckily I got on this one. So thank you, Sujit, for all you said. What have I been doing? Trying to move the needle for pediatric readiness in North Carolina. And I truly appreciate that it is a stepwise, a little incremental slog. So one of the things I recently did was work with, we have 13 hospitals in the UNC health system, I think about 13, and each managers meet twice a month. And I've been trying to push for them to set the agenda for a pediatric centered project. And again, STEMI and everything else takes, and adult sepsis all take precedence. So with the readiness survey and the fact that I'm on the EMSC advisory board for North Carolina, I was able to leverage facility recognition, which we really hope is going to come down the pike in the next year. And UNC tends to be terribly competitive with the light blue and dark blue compete, and there's red of so they tend to be pretty competitive. So just said, we don't want to be the only ones that are not PEDS ready. So I pushed all of them to finish the readiness survey because if I had to rely on them getting data for me, they would not do it. But then because of my hat, I can then look at the data both to drive facility recognition for the state as well as on a system-wide level. So when I mentioned it at the system meeting, there were immediately 5 or 6 people that emailed me and said, we would like to have help with our pediatric readiness. And then we keep having wave after wave of COVID. So that puts it on the back burner. But I do know there are folks out there who are interested. And I thought it was interesting too, because instead of reaching out to you know, our the main campus health center, where we do have, you know, pediatric emergency medicine specialists and everything else, and a PWD, they were reaching out to different hospitalists and community folks, which is, I think you probably heard me talk to Mark Auerbach about the importance of those folks. So those have been people that, so we're just trying to build interest. We just got data back, and they would like a presentation on both at the advisory committee level, and then for my health system level, they gave me permission to look at theirs. And we're not going to share by name, but then target work. So that's encouraging. I will say, working in a general hospital with the big ED, and it has been challenging with our C-suite trying to get both resources, space, and particularly nursing dedication for the care that we want to deliver. And we've recently had, I mean, everybody's short-staffed nurses, but we had a really great group of core pediatric EM nurses that are retiring. And so we're sort of having to reset the whole process. But with that, we managed to get it. Believe it or not, in the 18 years I've been here, we finally got a pediatric nurse manager. So, so there's somebody to partner with. So all I can say is it is a slow and frustrating process with some steps forward and some steps back. So, but I feel like we're making some progress. We're definitely better than we were when I showed up here 17 years ago. So.
Yeah, there's no small wins, right? Like there can't be any small wins. Like everything you said, I know that we've all wanted to move faster, but I think that's huge that they're actually reaching out to you, right? Yeah.
And
And
the VERB pediatric recognition program is enormous. So.
Well, we'll see how, but I also thank you for the offer for the resources. One of the things we're able to do is we've grown both our group and interest and everything else is, I mean, we actually have some really cool child life folks, and we've had actually other hospitals reach out for child life. So I will be reaching out to you about some of the resources that you have. And child life has been frustrated to get our adult nurses on board with some of the things that we do, because they've been there forever and they do it the way they want to do it. Whereas opening a pediatric urgent care with a child life person, we were able to have that level set from the beginning about this is how we approach patients. So we actually do it better in urgent care than we do in the ED. Yeah. I'm sad to say. Hey.
Anna, tell us what's going on in Massachusetts.
I think she's on mute.
Can't get off mute. Oh, too bad. Okay. Anybody else want to share? Nicole, Michelle, Evelyn, Amelia. I think it's helpful to hear all these stories and questions. Is there any, I mean, honestly, Sujit, I think the most powerful thing that you said was communication doesn't create more work, it is the work. And I think that's something that we really need to hear over and over again. And I hope that folks feel more adept at being able to tell these stories. I loved how you broke it down of the storytelling, and even almost this idea of these almost like plants of telling these cases over and over again. So people hear, oh, did you hear about that PEDS case? Did you hear about that PEDS case? It's such a really nice way of gossiping about pediatric readiness. Gossip works in some ways. Yeah.
I don't know if there's somebody else who's going to talk. I also want to tell people that it's funny that you asked me to talk about this. I still don't feel good at this. So I think it is okay for people to say, okay, like this is not my strength or my forte. none of this is part of how we were trained to work, is kind of like the value proposition in the selling of this. Sometimes we feel like, and yet all of us are so passionate about this that we should be. One of the pieces of feedback I got from one of my bosses just this past year was, as I was transitioning out, was she said, "I wish you told me even more about what you're doing." So I think that sometimes we have this tendency to not want to bother our leaders, like for those of us who are frontline staff or ER, to not want to bother ED leadership or to bother division chiefs. And I think that those folks are looking for this type of information, this type of storytelling, way more than you know. And you have this real, you have this really high value in their eyes as being somebody who's championing a cause for kids. And so I wish I had done more of it, honestly. If I had one regret, is that I wish I had communicated even more about these efforts and more about these needs. You spend so much time doing the work that sometimes you forget about this.
Yeah, thanks, Sujit. This was all very timely for me. It's kind of fun seeing some of the stuff that I'm doing, paralleling stuff that you've done recently or not so recently. But I really enjoyed the perspective of sharing things with staff. That's something that we're kind of focusing on separately in our system, and kind of similar to you, working across multiple hospitals within the system with different needs, different wants, different resources, and kind of trying to optimize our teaching strategies and our methods of communication with those individuals. It's I don't know. I really enjoyed all of the stuff that you had to share about that, and particularly about recruiting family members to become the advocates to encourage people to do the right things.
Yeah.
The mama bear is always the one that's like fighting until the bitter end for the kid, right? And if there's something that the parent could do that would make it better, I think that I really found that interesting. Something that we found that's been more and more helpful with regards to staff, mid-level management, and even folks in the C-suite as of late has been the effects that this has on employee satisfaction, employee happiness, and ultimately employee retention, because there's such a huge strain on employees, and people, when they're dissatisfied, they have a lot of incentive to leave. And so bringing that up with staff is something that people do enjoy, the things that we have found successful. And if people do enjoy things, bringing those things up, like you said, making sure that we communicate with those above us so that they know what's going on and the results that it has. But anything that we can do to help to keep our staff happy, to keep them educated, to help them feel like they're moving up and onward, and make them want to stay, is something that's super valuable to the organization.
You just brought up something that so I think some of you all who are in director roles or management roles already know this, but one of the things that most directors and managers and C-suite people are judged by is, do your staff feel like they have the equipment to do their work? It is a really, really specific worded question that's used as a method to measure whether or not your staff is in a working environment that keeps them happy and satisfied and not burnt out, what you just said. And so the ability to kind of relate pediatric readiness to actually being a detractor from people being allowed to have the supplies to do their work is a big, big one at the highest level. So I learned to rephrase it from one of my COOs that I was telling the story over and over again. She's like, what you're trying to say is the staff does not have the equipment to do their job. And that's like, yeah, that's right. She's like, well, that's important because that's one of the values of the institution, is you have to have the equipment to do your job. Yeah.
All great thoughts. Any last questions or comments?
Do you have any insights on how to get people to C-suite level people to pay for things like you know, if nurses want to work on, at least in our institution, if want to work on a project, then they have to be given some dedicated time. And particularly in this day and age, they are not volunteering their time because they're already, but we had problems with that before COVID too. So do you have any thoughts about how to leverage this information to get people to work on it?
I'll tell you the only two things that end up working for us. So our nurses in our system have what it used to be called a nursing portfolio project. Then it got called a nursing clinical ladder project. I got way into the weeds of like the whole nursing promotion schedule, because what I learned was that the majority of the work that the nurse was having to do that prevented them from wanting to do it was creating the content. So when I went to nurses that were engaged, I was like, why aren't you doing this portfolio project? And they're like, well, I don't have time to create the educational materials, to create the graphs, to create the data. So I said, why don't I do this? If you sign up for the portfolio project, I'll do all the work. It's like me, I was doing their homework for them, which was fine because I had the form. I learned what the form was for them to submit to get promoted. So I pre-populated everything. I gave them a library of things to review. And the only real work that had to be done then was that they liked to do was they had to be the ones that went to pre-shift. They had to be the ones that actually championed it and then get feedback. And so that helped. And then I don't know if this is going to be replicable, but in the process of me learning about the nursing promotions structure here, it was that I learned that there was a grant through the pediatric trauma section. So there's a level 1 trauma center. And part of that grant was specifically for funding for nurse education. Now, originally that money was tied up to just train pediatric nurses. But when I explained what we were doing, they said, well, this fulfills all the goals of being a trauma center, which is to do outreach and education. So we will pay for a select group of nurses to do this. So I think we got lucky on that one, but that was one where there's this little bucket of money sitting in somebody's corner that actually fit our needs.
I think, you know, the promotion piece is a big one, and we obviously are using the clinical ladder to provide support to nurses that are participating in this collaborative. So letters that go directly back to their nurse leadership so that they can receive credit and we can complete those forms for them. But I will just say that we're also working on the back end to see how we can actually develop on a national scale formal verification for the PEC role. And that's through, you know, our national organizations, and hopefully eventually work towards certification at the nursing level, because I think that really formalizes an opportunity for promotion by really, you know, validating this work. So we're working towards that, but we're still probably a few years away. All right. Well, I appreciate everybody joining. We're nearly at the top of the hour. Suja, as always, thank you for an amazing talk. Thanks for sharing such incredible information, and thanks for all the work that you're doing on behalf of children, and all of you as well. Thanks for being here. Thanks for your advocacy, and we'll see you next month. I hope you all really think hard about joining phase 2. We'd love to have you through that and continue to help support you as you implement this work. So, all right. Thanks, everyone. Have a great day.